Hello and welcome to today's webinar featuring Ilina Singh. I'm Claire Cameron, Engagement Editor at Spectrum, the home for autism research news and analysis. We'll begin the presentation in a moment, but first, know that we'll be fielding questions at the end of today's presentation, but you can ask them at any point during the session. To ask a question, submit them via the chat window to the left of your screen. And as always, I'll note that if there are any members of the press tuning in, you can only report information presented during this webinar if that material has already been published elsewhere or if you have first obtained express written permission from the presenter. Ilina Singh joins us today from Oxford in the United Kingdom, where she is a professor of neuroscience and society at the University of Oxford. At the university, Ilina holds a joint appointment between the Department of Psychiatry and the Faculty of Philosophy at the Oxford Uhiro Centre for Practical Ethics. Her work examines the psychosocial and ethical implications of advances in biomedicine and neuroscience for young people and families, and reflects a long-standing commitment to bringing the first-person experiences of children and young people into ethical evaluation, clinical decision-making, and policy-making. In 2014, Professor Singh received a Wellcome Trust Senior Investigator Award for a study entitled Becoming Good, Early Intervention and Moral Development in Child Psychiatry. Ilina has contributed to various scientific and policy groups, including the UK National Institutes of Clinical Excellence, US National Institutes of Mental Health, and the Nuffield Council on Bioethics. She is a co-chair of the Ethics Advisory Board for the EU AIMS Project on Autism Treatment and an expert advisor for the National Autism Project. Welcome, Professor Singh.
Thank you. Thank you very much, everyone, for joining us today. I'm really pleased to give this webinar, my first webinar ever. So I'm going to talk to you today about ethical issues in autism early intervention, focusing in the main on the 0 to 3 window. And I want to say at the outset that this is a new area for us. As you heard, we've just had a Welcome project that is beginning to think about the ethical issues in early intervention in psychiatry more broadly. So we'll be very pleased to hear your thoughts after the webinar. So I want to start by posing 3 premises of ethical intervention. These are not the only premises one could pose, but I would like to start with them because I think they provide a structure for the lecture that I'm going to give today. So the first premise is we know what we are intervening upon. The second is we can perform a reliable analysis of goods and harms of intervention and provide this to families. And the third premise is we have good reasons to intervene on which reasonable people can agree. And the lecture I'm going to give is really structured around thinking about these 3 premises as they apply to early intervention in autism in early life. So, as we know, and as those of you listening almost certainly know, there is a scientific and clinical case for early intervention in autism that is growing stronger really by the week as one follows the literature. The early developmental pathways of autism are increasingly well described, and there's a lot of literature coming out giving us more and more information both about the biology of autism and the different kinds of developmental pathways that autism can take. There is also increasingly good evidence that early intensive education and therapies can have an effect on improved developmental outcomes. And although there is still a question about how exactly we should describe those developmental outcomes, we certainly have more information that tells us that there seem to be improvements on the measures that we have been taking. We also have increasing information that interventions initiated before age 3 could have more positive impacts than those that are started later in life. And because of this accumulating information, various bodies, including the American Academy of Pediatrics, has recommended initiating interventions as soon as possible. So what that generally means is that as soon as the diagnosis is made, or even as soon as the diagnosis is considered to be possible. And so that, of course, means that we're increasingly trying to identify groups that are at high risk of developing autism. And one way in which the science of autism is increasingly trying to get to solidifying an intervention strategy is via autism genetics. And I know that there are other webinars in this series which give a great deal more information than I'm going to on autism genetics. But I'm just going to provide an overview of what the anticipated outcomes might be today. So one focus is on identifying autism susceptibility genes, and that is thought to help us identify autism earlier. Another focus is to try to identify autism susceptibility genes that would also provide more targeted and effective treatments for children who need them. And that development in the genetics of autism, most scientists would say, is still quite far off. So at this point, we're really trying to identify autism susceptibility genes in order to provide a way to identify autism earlier in life. And again, early identification is thought to support neurodevelopment throughout early life. And then as the genetics of autism improves, it could be that we might be able to have more targeted and effective treatments for children who need those treatments. So if one summarizes where we are in the genetics of autism, there is evidence that combined studies indicate that genetic factors contribute about 90% to autism, while environmental factors contribute probably no more than 10%. Twin studies show high concordance in monozygotic twins as compared to dizygotic twins. The rate of autism in siblings of autistic individuals is estimated to be about 4%, while the rate of autism in the general population is significantly lower. And so we're seeing more and more emphasis on high-risk groups that are sibling groups. We haven't found good evidence for environmental causation in the development of autism, and so that also goes to thinking that genetics play a very strong role. And so really when one takes all of this together, there's increasing evidence that genetics has an important role to play. It's also important to say that that role is complex. It's not yet very well understood, and that there's still a lot of work to be done, despite a lot of excitement about the genetics of autism at this point. So if we take all of this and we think about ethical premise number one, which is that we know what we are intervening upon, one question we could ask is, well, what is the intervention target? Has the science that I've just been overviewing got us to the point where we know what we're targeting when we try to intervene early in autism? And I want to argue that intervention at a very early stage is challenging because we lack symptom targets, and also because, as I've just overviewed, we lack a good theoretical understanding of the biological bases of autism. And so I think we need to accept that we're intervening in risk and not in a clinical condition when we intervene very early in life, and particularly, of course, when we intervene at a prodromal stage. And so when we identify high-risk groups, such as siblings, who are not yet showing symptoms of autism, in those groups, knowing what we are intervening upon becomes problematic because of the lack of symptom targets. We also need to ask under this premise how good, and by this I mean how predictive, is the risk assessment at the preclinical stage. And again, here we have identified high-risk groups such as the baby sibs, where we think because of the data that's emerging that we have a fairly good understanding that these are high-risk groups. And also, as I've just overviewed, we have an increasing understanding of genetic susceptibility and understanding of the neurodevelopmental pathways. So I think we can say that the risk assessment is getting better, but it is certainly not yet a very strong predictive assessment of outcome. And this, of course, leads us to sensitivity and specificity in autism risk prediction. So sensitivity is how good we are at predicting the proportion of positive cases of autism in the population, and specificity is how good we are at ensuring that no one is incorrectly predicted to develop autism. And both of those, I think, need to be kept in mind in relation to this ethical premise. Do we know what we are intervening upon? Because poor sensitivity and poor specificity are going to have lasting effects on children who might be predicted to have autism or not predicted to have autism incorrectly. It's also important, I think, given the science of autism and where it is, to consider in ethical premise number one whether we are good at predicting autism as a condition as it's described in the various classifications such as the DSM. Because we know that there's a great deal of phenotypic heterogeneity within autism. And so when we predict in high-risk groups such as the baby sibs group an outcome of autism, the question is whether we know enough about what kind of autism a child might have, or indeed whether or not they're going to have autism under any of those classification categories that currently exist. We know that some high-risk groups might not develop autism, that they might have neurodevelopmental challenges, but that they won't qualify over the life course for a diagnosis of autism. And we also have some evidence that even though one might be in a high-risk group, that doesn't necessarily convert to impairing conditions in all cases. And so this is why when we ask as an ethical question, what are we intervening upon, I think we need to get better at being able to say that we have sensitive and specific predictions and that we understand what those predictions are predicting for in the future of the child's life. The second ethical premise is about performing a reliable analysis of the goods and harms in early intervention in autism and providing this analysis to families. So in my view, that analysis needs to consider the risks and benefits of early intervention for children, for parents, and for the broader society. And I want to argue that intervention at different developmental stages changes the balance of goods and harms. And that is because the purpose and the outcomes of interventions differ at different developmental stages. And the way I think about this is in consideration of primary prevention and secondary prevention and the differences between them. The primary prevention is the total prevention of a condition or the cure of a condition. And secondary prevention is thought of as a prevention that will reduce the impact or the impairment of the condition, or that will slow the progress of the condition. It's possible that secondary prevention could also provide a cure, but normally secondary prevention is thought of as a slowing of progress or reduction of the impact or the impairment. So in ethics, we think about early intervention across the entire life course. And some of this way of thinking is related to real technologies that we have now and can use now. And some of this thinking is related to technologies that are anticipated in the future. And you can see that in my graphic here. And so I think we need to, when we think about early intervention options, we need to understand that parents are going to be making decisions about early intervention in the case of risk of autism in this entire trajectory. And they will have a number of different options for intervention at these different developmental stages. And again, the argument here is that when one intervenes, raises different kinds of ethical questions. So if we imagine that a family is having a baby and already has a child who is diagnosed with autism, then that family has a number of different options. One option is to not have any more children, which, if they're already pregnant, is not something that they have considered. Another option is to have some kind of genetic testing of an embryo or a fetus. And at this point, we have pre-implantation genetic diagnosis in the case of embryos, but families can also go and have other kinds of biomarker testing, such as BMA analyses. Another option is that if the family chooses, is to terminate the pregnancy. Gene editing is something that has been in the news a lot, particularly in the context of disabilities. It is not something that is available currently, but it is something that could come online in the future. And then after that, so those are interventions that take place prenatally, and after birth, there are a variety of other interventions that come into play. And I want to argue that there are, in the prenatal period, particular kinds of ethical issues arise, and that in the postnatal period, other kinds of ethical issues arise because of the ways these technologies that enable us to intervene at the prenatal stage and different kinds of interventions that occur in the postnatal stage. So I'm going to go through that in the next few slides. As I said, tests that could result in the primary prevention measures, which are at the prenatal stage, are already online. So there's chromosomal microarray, which, as the advert here shows you, is advertised as having a high diagnostic yield for children with developmental delay or autism. There's increasing discussion of prenatal screening for autism, and that is related in some ways to the development of non-invasive prenatal testing. So it was for a long time considered amniocentesis was itself too risky, and so many parents chose not to pursue it because of the other risks to the fetus. But the thinking now is that with non-invasive prenatal testing, we're going to see a lot more testing for all kinds of disabilities, including autism, of the fetus. And those tests, again, are just coming online now. They're not yet available for autism. So I want to consider some ethical arguments about conditions that can be identified or predicted prenatally. So these are ethical arguments that have been made in the literature, and these are not, this is not an argument that I'm putting forward as one that should be accepted. but I want to provide an overview of the kinds of ethical thinking that has already occurred around these technologies that are available to parents prenatally. So one argument is that if we can identify high risk of conditions that are considered in a child's life to be burdensome or impairing, then we have an obligation to eliminate that risk if we can. And we should use one of these technologies to do so. And so these are the technologies that have been available in these arguments: genetic intervention, embryo selection, sex selection, or indeed termination. Now, the arguments that are made for this position are utilitarian arguments largely, which suggest that eliminating the risk at the prenatal stage will maximize the good for the greatest number of people because it reduces burdens for the individual who would have one of these disabilities, for the family, and also for the society in the form of economic burdens. Julian Savulescu and colleagues have used a term called procreative beneficence, which is defined as an obligation to give the child the best possible chance in life. So this is the best possible child argument, which is used in favor of eliminating the risk at the prenatal stage if that risk can be identified. There are many arguments that have also been made against procreative beneficence, and I'll only be able to give a brief overview of that now. One argument is that eliminating the risk violates the rights of the potential person. That has, as I've said here, there are many, many arguments then about what constitutes personhood and how we identify that. There are also arguments based on the philosophy of naturalism, that one shouldn't eliminate risk in this way because it is unnatural and that it could potentially go against what nature has given. There's also a familiar, to those of you working in the autism community, a familiar argument about neurodiversity, that eliminating risk of difference at this stage reduces neurodiversity in the population. And related to that is an argument that the experience of autism shouldn't be assumed to be a burden for the individual or for society. And in fact, that the condition might actually bring benefits to the individual and to society. Another ethical argument that's been made about identifying risk and doing something about the risk at the prenatal stage is that if one can identify high risk in a fetus, one has an obligation to provide unbiased information to families and to support good decision making about next steps. And here Down syndrome has become a real test case for this argument, and that's particularly evident in the United States, where some states have passed what's called the Down Syndrome Prenatal Education Act, which is also known as Chloe's Law. And this law requires doctors to provide parents with information on support for children and families following a positive Down syndrome test, because it was thought that the very high number of terminations following a positive Down risk test were in part due to the fact that doctors were not providing positive information to parents. And this, there's been high penetration of Chloe's Law in America, as you can see here. But there is no, at this point, there isn't equivalent legislation in Europe or the United Kingdom, although we have bodies that are looking into this kind of issue in light of the non-invasive prenatal tests that are anticipated to come onto our National Health Service next year. And that advice is also likely to emphasize the need for unbiased and supportive information to parents. So that's really a space to watch in ethics as this non-invasive prenatal test comes online. There are various arguments that have been made against Chloe's law, which I think are useful to keep in mind. In the American context, there's concerns that it is biased and that it supports a pro-life political agenda. And among clinicians and some, actually also some autism activists, there are concerns that Chloe's law provides a door for the state to interfere in doctor-patient relationships and in doctor-patient communications, which is allied to the worry about a pro-life political agenda, but is also about the privacy of those communications and the need for trust between doctors and patients. And at this point, it's too early, of course, to say whether or not Chloe's law is having any effect on the termination rates in the case of Down syndrome. So this is that's a test case that I suggest might be useful in thinking about the need to provide parents with positive information in the case of an autism risk test at the prenatal stage. And then the third argument to consider about conditions that can be identified or predicted prenatally is the argument that if we can identify high risk, we actually have no obligations. And this is really used to support the parents' rights arguments, that parents have a right to make decisions about their offspring. And it's related also to women's rights to choose what to do with their bodies. And there are fewer ethical arguments really to line up for you here, but one question might be who would be obliged to pay for services in line with whatever decisions parents make, and that there might be some concern about how we prioritize resources to support parents' decision-making without any boundaries in this case. So if we think about the prenatal stage then and decision-making in relation to early intervention at this stage, a sort of summary of the goods and harms analysis might look as follows. That there are multiple factors to think about in this calculation, and those will lead to different decisions, but that informed decision-making by parents, which is free of external judgment or coercion or bias and free of state interference, is still the ethical gold standard. But that even as we prioritize the rights of parents, we have to understand that we are living in an age of technological change where parents are going to have access to safe, non-invasive, and very quick prenatal tests. And that because parents have access to those, the Down syndrome case suggests that we could risk what the autism community calls creating a world without difference. And that when those tests are available, what might matter most to parents is not actually whether they are robust predictors of a particular condition, but societal stigma, for example. So how parents make decisions once they have access to these tests will be an important investigation for us to pursue in order to understand how the ethics are working out in clinical decision-making that involves parents. So if we return again to ethical premise 2, just to remind ourselves of what that premise was, it was to perform a reliable analysis of goods and harms in early intervention in autism and provide this to families. And I said that the analysis needs to consider the risks and benefits for these three entities. So let's turn now to thinking about this ethical premise in relation to postnatal early intervention. And here on this slide, I'm quoting Professor Simon Baron-Cohen, who is a colleague here in the UK at the University of Cambridge, who, as you know, has been a pioneer in autism research. And Professor Baron-Cohen was interviewed by The Guardian in 2014, And his argument here in The Guardian was that really the best use of a prenatal test would be to say to a parent, your child has a very high likelihood of autism, and so postnatally we would like to keep an eye on that child in case they need extra support and provide that support very early in life. And he says here at the end of the quote, from an ethical point of view, if there was a screening test, using it for early intervention by a psychological approach would be quite risk-free and could carry a lot of benefit. And so I largely agree with the implication in this quote that postnatal early intervention raises different kinds of ethical concerns than prenatal early intervention, and that certainly the postnatal ethics is less fraught. But I don't agree that it is risk-free, and I'm going to show you why that argument is the case. So this is just a slide showing that we do have good evidence that early intervention is showing good outcomes in terms of autism development early in life. And this is a PACT study where this group has just published in October of this year a follow-up of the original intervention, which shows that the positive benefits of the intervention lasted for 6 years after the original intervention. And I think we can say that early intervention postnatally might have benefits for parents as well as for children in a range of ways. So involving parents as caregivers or even as co-therapists in this early stage would increase parents' autonomy and feelings of agency potentially. Early intervention can be delivered in the home rather than having to go to a clinic, and this could significantly ease parental anxiety. It could teach important parenting skills, and it could also strengthen parents' shared strategies for managing the infant, and that could have a knock-on effect on decreasing any relationship stress. And so we imagine that these kinds of early interventions postnatally, again, are in some cases with children who are already showing symptoms of autism, as is the example in the PACT study, but increasingly being delivered to children who are high risk of developing autism, such as the baby SIDS group. And those children would not yet be showing symptoms of autism. So if we think about that case of early intervention in high-risk siblings, then I think we need to consider that there are ethical risks. And one way to think about those ethical risks are within the family system. We know that interventions can have what's called iatrogenic effects, so potential harms. We need to remember that these are very, very young children, that for the most part they won't yet be showing symptoms of the condition we can call autism. And so one iatrogenic effect that would be ethically problematic is if the intervention itself created symptoms in the child or exacerbated the perceived deficits in the child. This might lead to a pre-stigmatization of the child that could affect outcomes over the course of childhood. And it could also pre-stigmatize any future children that the parents were thinking of having. We also know from research with families with children with a range of neurodevelopmental disabilities that mothers in particular suffer a great deal of blame and feelings of responsibility. And we find increasingly that although we would like biological explanations of neurodevelopmental disabilities to relieve blame of mother and parents, in fact, often it doesn't relieve that blame entirely. It just shifts the blame one can blame one's genetic heritage, but mothers can also feel much more responsible then for ensuring good developmental outcomes in the child following the diagnosis. So we need to understand whether or not very early intervention in a baby's life exacerbates feelings of blame in parents, and particularly in mothers, and makes them feel more responsible, or whether it makes them feel less responsible. And we know that these feelings of responsibility and blame also put significant pressure on the parental relationship. So there too, there are potential harms that we need to consider in delivering these early interventions in very early life. An area that has received really no research attention is what the impacts might be on the high-risk sibling. So we imagine that there is a high-risk sibling living in the household who might be aware that a baby is receiving very early intervention for the condition that the sibling already has. And siblings in this case will differ as to how much of that they understand, but certainly over their life course it could have impacts on how that high-risk sibling perceives their own abilities and capacities and the value of having autism. Beyond the family, of course, we also need to think about the potential societal impacts of very early intervention in autism. So flourishing, which is a term in ethics that we think about in relation to child development. So, and we sometimes ask, well, what is a good life with autism? And we would not want flourishing in autism to be reduced to some kind of a checklist of behaviors or traits that are isolated or targeted by interventions. Because, of course, flourishing is much more than that. And early interventions are targeted to specific kinds of behaviors and specific kinds of capacities. And we just need to remember that targeting those capacities is not targeting the flourishing of the child as a whole child. We also wouldn't want those behaviors or traits to become entirely synonymous with a negative condition, because they can also be thought of as being part of a valued part of a person. And so if parents feel compelled to continually correct the child in these particular ways, thus hoping to impact on the child's developmental trajectory, then that child may begin to struggle to see those particular behaviors and traits as part of their valued sense of self. There's also been some work by Lonnie Zweidenbaum and his colleagues on the need for cultural diversity in early interventions, and really the need to understand how cultural diversity within families might affect families' developmental priorities and goals that parents have for children, and how that might impact how they view early intervention and how accessible it is to them. So again, if we want to summarize the goods versus the harms of early intervention at the early postnatal stage, we might summarize it as follows. That one of the keys to ethical early intervention at this stage needs to be a commitment to following children over an extended period of time, like the PACT study did, to understand not only the extent to which the intervention reduces symptoms or attenuates symptoms, but also how it affects the child's quality of life as in a more holistic way. And in ethics, we have a way of thinking about a child that's called a right to an open future. And we need to have some consideration about whether early intervention supports or inhibits that right to an open future, bearing in mind that severe neurodevelopmental disability, of course, will be burdensome and impairing in life, but that, again, the qualities of a child's future at this very early stage still need to be considered open, at least for the time being. We also need to investigate the systemic impacts of early intervention within the family, as I've reviewed. And we need to think about this particularly in relation to the parental autonomy and parental agency, so the degree to which parents feel in control of their interactions with the child, and whether they feel enabled to interact with the child in ways that feel both to encourage children's flourishing, but also to encourage parents' flourishing. We need to consider whether or not early interventions impact blame and responsibility in positive or negative ways. And as I've said, I think we need to pay more attention to the impact of early interventions, particularly when they happen in the home, on siblings' behaviors and self-perception over developmental life of the sibling, taking into account the extent to which the sibling is able to engage in an understanding of self-perception at this stage. So the third and final ethical premise was we have good reasons to intervene on which reasonable people can agree. And here, of course, we have a very robust challenge from the autism community that I think we should not by any means ignore in relation to early intervention. So the challenge here there is varied, and I'm not going to have time to really go over it in any substantial detail. But the arguments that early intervention would reduce neurodiversity, that it would reduce respect for human variation or cognitive styles, that it would set in motion reductive and binary models of neurodevelopment in public perception, and reduce the world of difference, I think need to be taken into account. Another way of thinking about this is that a lot of the policy arguments for early intervention have been made in economic terms. So neurodevelopmental disabilities are expensive in economic terms for societies. They are often referred to as societal quote-unquote burdens. And the argument could be made that children and their futures are increasingly being valued in economic terms. And so while I wouldn't want to deny the importance of economic models of child neurodevelopmental trajectories, of children's contributions to society and so forth, I think it is important to understand that economic models of good child outcomes are just one kind of model, and that they have implications for justice considerations in relation to how we prioritize health coverage, who is allowed health coverage, how we prioritize education, particularly inclusive education, and also ultimately for how we think about reproductive choice and who should pay. And so these are substantial ethical concerns that we need to keep in mind as we continue the work on early intervention in trying to do the best that is possible for children and for families as we move forward. We also need to consider, I think, whether the emphasis on early intervention that we have both in the policy and funding world today biases research on lives that are lived with autism. And again, the autism community has been quite active in saying that they would like more of a balance, that there is an understanding that research on the biology of autism will contribute eventually to better interventions and better outcomes in autism, but that there is an imbalance in research attention to improving the quality and understanding of lives with autism, particularly in relation to education and health services and the needs of carers. who support people with autism. And of course, there's also a real lack of attention to how to integrate autism voices, particularly the voices of people with low functioning autism, in the debates about how best to care and intervene in autism, and how those subjective experiences and needs relate to the research agendas. So I think a key question really for us to consider in relation to early intervention that would help us get a handle on what ethical early intervention might look like is, well, what is a good life with autism? Is that a question that we know enough about? From whom should we be getting information about that question, and how should it relate to the very positive work that's coming out, particularly on early intervention in the very early life of children? And so finally, I think that if we can integrate ethics with basic research and with intervention science, and if we can make room for societal deliberation and use policy making really in a way to integrate all of this knowledge, then I think we have a very good chance of having ethical and acceptable early interventions in autism. Thank you. That is all that I have for you today.
Thank you very much, Professor Singh. We have a couple of questions. One question is on how has the ethical conversation around early intervention changed as the neurodiversity movement has grown?
So I think the ethical conversation has taken account of the idea that that understanding, so the question I just asked at the end, what is a good life with autism? What the ethical community, I think, has come to understand is that we need to, that the experience of people with autism, and particularly the different ways of flourishing with autism, is something that but we as ethicists have not paid sufficient attention to, and that hasn't been given sufficient research attention in science either. And so ethicists are increasingly looking at the question of diverse understandings of flourishing in the autism community, and how autistic experiences can contribute to an understanding of flourishing.
Another question we have is on what you were saying earlier in your presentation about genetic screening. Many of the genes that are tied to autism occur in the wider population, and the genes that are considered high-risk genes for autism often occur in a very small percentage of people with autism that we know of. How important is this to take into account if you are getting genetic counseling and genetic screening when making these kinds of early intervention decisions?
Yeah, I think this is very important to take into account. And genetic counselors, I think the ones that I've spoken to about autism are really concerned about both how good the predictions can be. So in some respects, one has genes that point to rare conditions and highly penetrant rare conditions where the prediction can be quite good and very helpful. In other situations, we have genes that predict certain kinds of neurodevelopmental challenges, but we're not sure exactly what those challenges will be. And so we can, I think, as we go forward, we just have to hope that the understanding of autism genetics gets better and better and allows us to make better predictions. But certainly where we can make very good predictions that will impact the quality of a child's life or a quality of family decision making, that will help the family ultimately.
Another question we have from our audience is, where can people best go to get information on the impact of having an older sibling with autism on a younger sibling if you're a parent?
That's a very good question, and I don't actually know the answer. There is, here in the UK, the group at Birkbeck, which has the Baby SIDS lab, has put out a lot of information on their research. Now, I don't know if that includes information for parents, but I think that that's a very good place to start. So that's Birkbeck University, and Professor Mark Johnson leads that group. And I would look at their website and see if they have any information on that.
Another question is, will things like the ICF core sets, which are supposed to take into account an individual's ability to function and their quality of life, go some way to providing that measure of what is a good life?
They may go some way towards doing that. So we have colleagues in the Netherlands who at the moment are actually testing the World Health Organization quality of life measures in the autism community to understand whether or not the standardized measures that we have for quality of life take sufficient account of autistic experiences. So that's to say that one problem we have with those standardized quality of life measures is that they were not created for people with autism. And we're already finding that some of the questions go to a neurotypical experience rather than a neurodiverse experience, and assume that the neurotypical experience is normative. So we may find that we may need to change some of those measures in order to get good data that is relevant to the autistic community.
And finally, why do you think there has been so little research on the impact of the sibling who has possibly already been diagnosed with autism, is a high-risk sibling, of their younger sibling receiving early intervention?
Well, I think that the identification of high-risk SIBs is still relatively new, and I think that that the scientific funding has gone in other directions. And as I pointed out, lives lived with autism receive less research attention and less resource from funders. But now is really the time, as we really understand risk in this sibling group better scientifically. It's also an opportunity to have more information on the experience of those siblings. It could easily be worked into existing scientific projects.
Okay, that's all the questions that we have for today. So we'd like to conclude this webinar just by letting everyone know that a complete replay of the presentation will be available on the Spectrum News site in a couple of days. The webinar is part of an ongoing series, so please check our site for upcoming talks, which will be announced soon, and for video archives of previous webinars. Our next webinar will be on January the 25th, 2017, and that's with Summer Bishop, and the focus will be on autism diagnosis. Thanks again, Professor Singh, and thank you all for tuning in.